So the impetus behind this paper was to evaluate whether the Society for Cardiovascular Angiography and Intervention's shock classification or sky shock classification could be applied in patients with other forms of shock besides cardiogenic shock. The sky shock classification was initially developed in 2019 as a way to grade the severity of cardiogenic shock to facilitate communication between different providers. It's a five-stage classification, including patients who are at risk, stage A, who are hemodynamically stable but have an acute cardiovascular condition that could predispose them to shock, ranging all the way through stage E, which is severe refractory shock with actual or impending circulatory collapse and extremis. Hi, this is Jake Genser. I'm a critical care cardiologist at the Cardiac Intensive Care Unit at Mayo Clinic in Rochester, Minnesota. And I'm excited to share with you a brief summary of my recently published paper in Mayo Clinic Proceedings entitled Shock Severity Classification and Mortality in Adults with Cardiac, Medical, Surgical, and Neurological Critical Illness. The motivation for this study was my involvement with outcomes research involving the sky shock classification, which was introduced about 5 years ago as a way to classify the severity of cardiogenic shock. And the idea behind this is that the manifestations of shock are generally conserved across etiologies, both within the cardiogenic shock state, but also, as I believe, across other non-cardiogenic shock states. And so many studies, including my own, have found that the sky shock classification is highly effective for mortality risk stratification in patients with acute cardiovascular disease. However, there's no reason to think that the manifestations of shock would not be the same in patients with other forms of shock besides cardiogenic shock, because these are physiologically conserved mechanisms. And so the purpose of this analysis was to demonstrate that the sky shock classification could still provide mortality risk stratification across the spectrum of critical illness, including patients with and without heart disease. For that reason, I was able to assemble a large cohort of more than 20,000 ICU admissions at Mayo Clinic, Rochester between 2014 and 2018, including patients in the cardiac intensive care unit, medical intensive care unit, neurosciences intensive care unit, and surgical intensive care unit. And I was able to use time-stamped physiologic data to assign the sky shock classification, which is a 5-stage grading system, from A, which is the absence of shock, to E, which is refractory shock. I was able to assign that every 4 hours during the first 24 hours, and then to look at the maximum of all those to define the maximum shock severity in the first 24 hours. What I found is that most patients in my cohort developed shock at some point. And in this case, shock was defined as stage C, D, or E, which involves the presence of objective evidence of hypoperfusion or the need for vasopressors. And I saw a very impressive stepwise increase in mortality, going up from about 4% in stage A to over 40% in stage E. And this dramatic difference in mortality was seen even after adjustment for standard mortality markers such as the Apache score. But the real interest in this paper was looking at the sky shock classification in each of the 4 different ICU populations. Now, as I'd previously demonstrated, it performed very well in the cardiac intensive care unit. It still performed well in the medical and surgical intensive care unit, but it did not perform quite as well in the neurosciences intensive care unit, which didn't surprise me because, again, the types of patients admitted there are generally admitted for reasons other than shock. But even though there was good risk stratification in each of those other ICUs, the observed mortality at each stage of shock severity differed quite a lot. In general, what I found is that patients in the surgical and neurosciences ICUs overall had lower mortality, even at each stage of shock. And as I explored this further, it seemed to really relate a lot to patients being admitted from the operating room in PACU, presumably in many cases after elective surgeries. And of course, these surgical critically ill patients tend to be quite sick at the outset, but then often recover quickly because the main issue that made them sick has been treated surgically, and generally speaking, they had some level of health before their operation. But overall, I found a very consistent association in the cardiac ICU, medical ICU, and surgical ICU between escalating shock severity defined by the sky shock classification and both overall and adjusted in hospital mortality. I found something very similar when I assigned shock is a binary outcome, and shock again was defined as stage C, D, and E, whereas no shock was A or B. B is a pre-shock state that doesn't always progress to shock. And again, consistent findings that patients with shock did worse. And in fact, the prevalence of shock differed quite a lot between the ICUs, which seemed to correlate to some extent with the outcomes associated with it. So in the end, I think that this is a very nice proof of principle study that shows not only that the severity of shock can be assigned frequently during the ICU admission, but also that that assignment of shock is able to predict survival outcomes beyond standard markers of illness severity, which are used in clinical care. It also shows that the SkyShock classification is not just a cardiology tool. It's a universal tool that can be applied in patients with different forms of critical illness, and therefore serves as a universal language for discussing shock, which is how it was initially designed. And this is something that we use clinically at Mayo Clinic. We have an electronic health record algorithm that can help us assign the SkyShock stage in real time. We're currently doing this in our cardiology floors, but now this research serves as the impetus to potentially apply this more broadly with the goal of providing bedside care for patients with early or impending shock. So I thank you very much for your attention, and I hope you enjoy the paper.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.